but there are no new articles lately that are of any value. I did recently review a super cool study that they wanted to publish on a new diagnostic method which involves no surgery for endometriosis. And the journal that was doing the study asked me to actually check it out and see if it was appropriate for publication or not. And it wasn't, because it was still not ready. But it was super cool to see that people are working on novel ideas. And this was like completely wild stuff that I'd never seen before. I think Tarek is having trouble loading us up on TikTok at the moment. What's going on?
It's just too pink.
Oh, don't worry about pink.
Hold on.
I don't think I have a pink filter. So if you have questions tonight, guys, just put up your questions and we will be happy to answer your questions. And we can go from there. In the meantime, nothing super exciting. There is a bit of a growing debate in the literature about whether or not we should be doing PGT, pre-implantation genetic testing. Dr. Bob Casper is now arguing we should not, which is, again, interesting. And others have argued very strongly that we should. So kind of cool to see what's going on with that. And hopefully someone will finally do the right study. The right study has not yet been done, ironically. So we're still waiting for that to happen. But we will see, what happens. Hopefully someone's going to come out with the right answer for us. So we'll know if we should or should not be doing PGT. I will probably in the near future review an article on mosaic embryos, where more and more they are showing that mosaic embryos could actually end up being normal. Even high-grade mosaics can end up being normal. So very interesting data. And if you don't know it already, there are two different ways to test embryos. And the two different methodologies are quite different, and they can yield different responses, with one overcalling the number of abnormal embryos and the other one undercalling it. So we're kind of stuck in the middle as to what to do. So I'm hoping people have started asking their questions.
I didn't see the prices and services on your website.
We don't have, services we do. It's all over the website. Our prices are not posted there because it varies based on who you are and where you are. So we have different prices for Canadians versus non-Canadians. If you're in Ontario, it might be free because we have government funding. So just reach out for a consult and we'll go through the pricing with you. What I can tell you is we are one of the most inexpensive in the country, and certainly in North America. So we are happy to share our prices with you, but we don't put them up on the website. I feel like the cost should not be the determining factor in whether you come to us or not. It's whether or not, A, you want to get care from us because of our model and the way we practice and the care we provide, and B, a little bit about whether or not we want to take your case. So we want to know about you and what your goals are and what you've done so far and where you've done it and what your experience was, and whether or not we can help you in the way that you want. Sometimes I have to tell people no because it just doesn't make sense for them to do what they're asking. So we don't dive into price. We have very, very reasonable pricing. I can tell you it starts as low as $6,250 Canadian. So check us out first and see if it's a good fit. And then if it is a good fit, we're happy to share pricing with you.
Just had a lap yesterday and found out my ovaries were attached to each other due to endometriosis.
Yeah.
Would this have likely been the explanation for my unexplained infertility?
Absolutely. You're no longer unexplained. You have endometriosis. So remember that endo can reduce your chances of success by up to 50%. And the endosurgery can very significantly increase your chances. If you had ovaries that were touching behind your uterus, they're called kissing ovaries. And that generally suggests that you have quite severe endo. So that is a significant issue for sure. So yeah, we would not call you unexplained anymore. We would say that you have endometriosis as your diagnosis.
I have a hysteroscopy coming up to remove minor scar tissue from a C-section. They will use general anesthesia. I'm so scared. Is it normal to use general anesthesia?
Yeah, I mean, when we do it in the office, we use conscious sedation. But if you're doing it in the OR, we always use general anesthetic unless the patient has a contraindication to general. in which case you can do it under spinal. So if you were really terrified of being put to sleep, you can ask for a regional, which is a spinal anesthetic. It'll work equally well. But we put almost all of our patients to sleep. Normally, if you have scarring from a C-section, they probably mean you have an isthmocele, which is that defect in the wall of the uterus where the C-section scar was. And that just takes about 10-15 minutes to resect or burn. So it's usually not a huge issue, and it's a quick, easy surgery. And risks are minimal if you're a healthy person and you have good doctors working with you and for you.
I have 8 embryos sent for PGT testing. Embryo grading was 6 BB,
Wow.
4 BB,
Good.
3 BB,
Good.
4 BC,
Okay.
and 3 BC.
Okay.
No options of AA or AB.
Right.
Is there still a chance for me? I'm feeling defeated.
Oh, no, those are great embryos. A 6BB is an amazing embryo. A 4BB is a great embryo. A 3BB is a very good embryo. The BCs are a little bit less, but all of those embryos have a chance. So don't feel defeated at all. You've got a lot of good embryos. As long as you have some that are genetically normal, your chances are actually quite reasonable. We would never balk at BB quality embryos. Those are nice embryos. So you should actually be quite pleased.
Hi, Dr. B. Does a hysteroscopy look at both the fallopian tubes and uterus?
Well, it looks at the opening to the fallopian tubes as they're in the uterus. So if you guys are looking into the camera, you would see like a top to the uterus like this. And then kind of here and here, there would be these tiny little holes, which are the holes that lead up into the fallopian tubes. So we can see those holes, but you can't see into the fallopian tube. That is not possible with any technology that's currently available, at least from that side. You can do it from the other side. There is something called falloposcopy, but you need a very, very small camera for that. So like a 1 millimeter soft camera, and you're probably like horribly damaging the tube by shoving it in there. So from the uterine end of things, you can see the openings, which are called the cornua, to the fallopian tubes, but you cannot see the inside of the tube itself.
I'm 32 and had 3 losses, 2 blighted ovums and 1 ectopic.
Oh, I'm sorry.
And 1 live birth in 2021. We
Okay.
have 9 embryos sent for PGT.
Okay.
What percent should I expect to be normal?
32?
32.
About 30-35% would be not normal. The rest of them should be normal on average. Now, sometimes it's higher, sometimes it's lower, but on average, that's what you're looking for.
What anesthesia is used during an egg retrieval? Can't they use the same anesthesia during a hysteroscopy as during an egg retrieval? Are there alternatives? Doc recommends using anesthesia.
So during our egg retrievals, we use conscious sedation, so Versed and fentanyl. During hysteroscopy, you can do the same. You can use propofol. You can use general anesthetic. There's all sorts of different approaches. So here in the office, we just use conscious sedation. You can also use a regional anesthetic where someone places a spinal anesthetic. That's also very reasonable.
I'm 25 weeks. Is it normal for a baby to still be horizontal and super low?
Yeah, at 25 weeks, it's not relevant which way the baby is because they can still do donuts and donuts until the end. And so at 25 weeks, it absolutely doesn't matter which way the baby is facing. You can be upright, you can be vertex, you can be breech, you can be transverse. It makes absolutely no difference. That baby will very, very likely continue to turn multiple times before it engages into the pelvis and gets stuck there.
How can NAIT impact surgery? Nate?
Neonatal alloimmune thrombocytopenia. NATE should not impact your surgery. NATE's a problem if you're pregnant because your antibodies to platelets can attack your baby's platelets, but I'm not aware that it's a specific problem for surgery as long as your own platelet function is normal. Now, if for whatever reason you have dysfunctional platelets yourself, that's a whole other issue, but normally it's attacking somebody else's platelets, not yours necessarily.
What do you think of lip procedures for patients with low levels of lymphocytes?
Yeah, so if you have low antigens or antibodies, to paternal antigens, lymph therapy can be beneficial. It's very controversial. There are literally gajillions of studies showing benefit and not benefit. Nobody knows for sure. For the most part, those of us that do lymph therapy or offer reproductive immunology services are believers in it. And it can work. Whether it's the be all and end all, no, I would never say that to anybody. But it does tend to help some patients, and so they benefit from it. And we do offer it now here as well.
Good evening, Dr. V. Lupron injections can be administered subcutaneously in the abdomen instead of intramuscularly. Yeah. Thank you in advance.
Not for depot. The depot Lupron shots have to be intramuscular. It's the way that they release slowly. If you do it sub-Q, it will not have the same effect.
Thoughts on this protocol?
Okay.
Aspirin.
Sure.
Letrozole.
Like it.
Trigger shot was added since clinic needs it for scheduling. Low dose HCG after. Estrogen patches start on trigger date 2 days after trigger is progesterone injections. 2 days after progesterone, I start Medrol and Clavulin. Estrogen patch and progesterone to be continued until pregnancy test. Any thoughts on why estrogen was added in this protocol? Thank you, Doc. You are the sweetest.
Aw, thank you. Okay, so we try to avoid estrogen, and just giving you estrogen without knowing if you need estrogen just to me seems inappropriate. So I wouldn't do that. I would measure you and see if your lining has developed from the letrozole, and certainly if you don't need estrogen, don't take it. If you do, the patch is fine, but you want to use the lowest dose of estrogen possible. So make sure you're on a very low dose patch. As far as the progesterone, you always want double, so vaginal and injectable, and you should have your levels checked. The aspirin and the letrozole are perfectly fine. Low dose HCG has been proven to not be of any advantage or benefit, so it's probably an unnecessary shot that you're taking. The HCG trigger for timing, not beneficial, not harmful. It just is what it is. But I don't know how that helps you with the timing, because you still can't do it till your lining has thickened enough. So the timing is determined by your lining, not by anything else. So the HCG trigger is not necessarily going to help you. And you don't need to trigger. You can just take progesterone. We literally do that all the time.
I've been going to IHR, and so far I've had egg retrieval turned to 1 blast, 3 AA. I'm 35 and have low AMH.
Okay.
Would you do another retrieval or move forward with a transfer?
Oh, that's a great question. So the first question would be, how many kids do you want? And then the second question would be, essentially, did they do PGT testing for you? So if you want to bank embryos so that you have all your embryos and then you try to get pregnant, in the event that if you do get pregnant, you're now going to be delayed probably on average minimum of about a year, year and a half before you can get pregnant again, then you definitely want to bank embryos. Because if you want more than one baby, that's not going to be possible if you already have very weak ovaries. A year and a half later, you might not be able to produce any eggs. So in that situation, you may want to bank embryos. If you are happy with one baby, or you do not want to bank embryos because of cost or moral reasons or whatever it is, then I would fire ahead and transfer the one you have. If that one doesn't work, you're not going to be behind by a long time in making more embryos, so there's no harm done there. But if it does work, you got to understand that it'll be a long time before you get a chance to come back. And if you're already that weak that you're only producing one egg, one embryo, it is very likely that it would be difficult for you to produce more. I don't know where IHR is, but nah, probably pull up God knows what. You got to be super careful with what you type into the internet these days. Yeah,
that's what I was doing.
ChatGPT lied to me. You should see our new post. Yeah.
What is the average wait time to have a second opinion with you?
Depends on how urgent it is. So we do triage your consults, guys. So, if you're older, if your ovaries are running out, if you've got cancer, we'll see you very quickly. If it's garden variety, you're healthy, there's no medical emergency about it, probably a month or two. And then it depends on whether you want to see me, my nurse practitioner, you want to see my family doc that works with us who's specializing in fertility. It's all dependent on who you want to see. So they all work with me, and I do end up seeing you and taking care of you. But sometimes to get you in, it's faster for me to have them see you first. So we can get you in within weeks, sometimes a month or two.
I get cramps, no menstrual blood, not pregnant, and I'm 35 years. Please help.
Oh, wow. Well, I'm sorry you're getting cramps, not pregnant, and you're 35 years dealing with that. But I need a consult. There could be all sorts of different things going on there. So could be a problem with your hormones, could be a problem with endometriosis. Your cervix could be blocked. You could have scarring in your uterus. I need loads of information to be able to figure that out. So if you're local, contact your family doc and have them send a referral. If you're not local, just ask for a consult. I'll be happy to help you out.
I'm 45 years old and cannot get an IVF treatment in Canada.
45?
Yeah.
We'll do your IVF treatment. We do it all the time. Why can't she get an IVF treatment in Canada?
I don't know.
Okay.
Why is that, she says? She's asking that.
So what you need to be advised of is the risks and the benefits. So at 45, your chances of success are very low. You're probably looking somewhere between 5 to 10%. So as long as you know that, and you are financially prepared for the outcome, we're more than happy to help you out. I have several 44-year-olds, 45-year-olds who have tried and been successful in just the last year. So, sometimes it works when you do all the right things. The problem is, A, it's very expensive because you probably have to do it multiple times. And B, you need to be prepared emotionally for the roller coaster because sometimes we get no embryos that are viable from you. And C, you've got to be prepared for, all the injections and all the retrievals and all the, sort of physical, emotional, mental trauma that goes with this. Excuse me, and financial trauma as well. So as long as you're prepared for it and you feel comfortable that you've been adequately advised, we're happy to help you out. The one thing I always turn to here is this Israeli study that we've posted before and we've talked about before. So there's this brilliant study in Israel where they took in women over 40, over 43. And they counseled them and consulted them and explained to all of them universally that they had a less than 5% chance of success. And they were very clear about this. They said your chance of success is less than 5% for a live birth. So they were really crystal clear. They delineated everything. They understood that patients were told the truth, like super, super clear, and because it was part of a research protocol. And then on the way out of the clinic, they asked the patients to sit down and fill out a form. And on the form, it asked them, what do you think your chances of success are after discussing this with the doctor? So keep in mind the doctor had told them that their chance of success was 5%, and the average was 49.3%, I think. So almost half the patients thought, all the patients thought that they had like a 50% chance when they had been told 5. So you need to make sure you understand the numbers that are being expressed to you. So when I communicate it to patients, I'll tell them, you have a 5% chance, which means a 95% chance of failure. And if you're comfortable with that and you want to move forward, it's not my place to judge you and say no. I will tell you, these are the risks, these are the benefits, these are the costs. It's your decision. As with anything in medicine, as it should be. But in terms of whether or not you should do it, that's a decision for you. And if you have a partner or family or friends or whatever that you make all together. I'm not going to decide for you. So just contact us and I'll help you. The reason why other clinics aren't doing it, because it drops their success rates, right? I mean, we all pride ourselves on being very good. And if we're dealing with people that have a 5% chance, no matter how good we are, that's going to pull our success rates down. Most clinics don't want to do that, and they feel that it's going to crush their rates. Other places genuinely don't want to because they may feel that it's unethical. Considering the fact that most fertility centers just keep pushing people into IVF, I'm not sure how much ethics has to do with it, but that's just my opinion.
She further goes on to say, I will be going to Turkey for an IVF treatment and they do not have an age limit.
Yeah, we don't have an age limit, so just come see us. You don't need to go all the way to Turkey. I've had one patient with Turkish IVF, and it did not work. So yeah, you don't need to go to Turkey. Come to us. I mean, generally speaking, we do a much better job than any of the Middle Eastern countries in North America as a whole. But come see us, see what you think. If you're happy, great. If not, go to Turkey. I mean, I hear Turkey is beautiful. Tark went to Turkey.
I love Turkey.
How many years ago was that? 2 years ago?
Most recently, no, I went.
Was it during the
last year.
pandemic?
I went recently.
Yeah, it was during the pandemic.
Yeah.
Right?
Yeah.
Like near the end of the
Near the end
pandemic
of it,
or something.
yeah. The pandemic was over in the rest of the world. It was just still here in Canada.
Yeah.
That's kind of when I went.
And you love the food. Amazing food.
Amazing food.
Yeah, I remember you telling me that.
Amazing.
Yeah.
Very.
We got to go together.
Yeah, you know
sometime.
what? Even if we go there just to go eat, it's worth it. That's how it is.
Yeah, let's clear that with the wives, buddy.
Yeah. I also need polyps removed before a transfer.
Hysteroscopy for polypectomy. That's easy. Yeah.
What is the reason to be induced at 39 weeks of pregnancy?
Oh, watch our video on YouTube. Is that our second most? No, third most.
It's a big one, yeah.
It's a big one. We have a big video on YouTube. So go to our YouTube channel, Dr. Victory on YouTube. Check that out. So it lowers risk of cesarean section. It lowers the chances of stillbirth. It lowers the chances of maternal preeclampsia, and it lowers the chances that the baby will be admitted to the NICU or that mom will be admitted to the ICU. So overall, it's safer. Satisfaction rates are the same between induction and natural labor, and so there is no reason to not be induced. It's safer, it's effective, and it actually reduces your complication rates. So I love getting into it with certain members of the healthcare community who believe that they're more educated than everybody else and say that you should not have any kind of intervention in pregnancy, but they're just flat out wrong. And I will happily take on anyone that wants to challenge that and debate it with me live anytime. So if anyone's watching and believes that no intervention is appropriate, DM us or email Tarek, and we will happily set up a show where we can debate it evidence to evidence. You can bring your evidence, I will bring mine, and we can go over it and see, what the evidence shows.
How soon after stopping progesterone should I get my period?
It depends on what you're stopping it from. If you're stopping it because you're prepping for an FET, usually like within a week. If you're stopping it because you just took it for 10 days to get a period because your periods are irregular, usually 3 or 4 days.
Squeaky chair.
That is a squeaky chair.
Right? It's every time I move.
It's quite squeaky.
Yeah. Would you recommend removal of endometriosis and fibroids before transfer, or just the endo and down regulation may suffice?
So there's no question that endosurgery can improve your chances. So that is a clear answer for sure. Fibroids, it depends on where they are and how big they are. More than 4 centimeters in the wall of the uterus, they should be removed, or any fibroid that is pushing into the cavity of the uterus should be removed. Other fibroids on the outside of the uterus, they're pedunculated, they're subserosal, they're not particularly huge. They don't necessarily need to be removed.
Hello, Dr. VNT. Is there a purpose to being on antioxidants when you have an egg donor and you're doing a FET? Can you be on too many, for example, being on all of these Akai, CoQ10, NAC, ALA, PQQ?
Yes, you can be on too many. If you're on too many antioxidants, you can actually do something called reductive damage. And we're just about, in fact, I was on the phone today with a gentleman who is a rep or distributor of a company that lets us measure the amount of oxidative and reductive damage in semen and in follicular fluid. So we're going to be trialing that to see how it works. But basically, if you have too many antioxidants on board, you can actually do damage. So is there potential for excess? Yes. From the ones you mentioned, I doubt that would occur, but it is possible to overdo it for sure. Why would you take it if you're doing donor egg? There's still going to be inflammation in everybody. So, and some oxidative damage. So you're trying to undo that oxidative damage and reduce your inflammation. If you're super healthy and you don't have a lot of inflammation, you don't necessarily need them.
Chicago, Illinois.
Oh, cool.
That's where...
One of my favorite cities in the world.
You know what? That was... So when we went to Nashville, that was what the commentary that me and my wife had. The Chicago's just...
It's fabulous. I
amazing.
love Chicago. Chicago is an amazing city. My favorite restaurant for breakfast in the world is in Chicago, the 11 City Diner. Love it there. Fire away.
So the IHR clinic,
Yeah.
they answered and said it's in Chicago as well.
Oh.
The doctor there, his name is
IHR.
Dr. Cohen. He's also from Canada. He doesn't seem as awesome as you.
Oh. So there was a doctor, was it Cohen? There was a Dr. Cohen that was there years ago who ran FCI, Fertility Center of Illinois. Was it Cohen? Maybe it wasn't Cohen.
Cohen's a common name.
He's, I don't know a Cohen in Chicago right now. In any event, thank you for the compliment. But if you're in Chicago, just come see us. We're way cheaper and we'll be happy to help you out. And it's not a long drive. It's like 4 hours, 5 hours to get here. Like 40. How long is it, the flight to Chicago? It's like an hour, right?
Oh, flight's an hour.
Detroit to Chicago is an
that's
hour.
an hour.
So-
That's a breeze.
Yeah, so we're happy to help you out. The neat thing about Chicago is in Illinois, you guys are a mandated state, so you typically have insurance for IVF if you have insurance there. So that's a little bit more complicated with us, but by all means, if we can help you in any way, let us know. We'd be happy to. And enjoy Chicago. I love it there. Have you ever eaten at the Fig and Olive?
I wanted to.
So good.
I really wanted to. You told me about it last time I was there.
So good. Although last time I was there, it wasn't as good, but
Really?
it is
Still
an
good?
awesome. It's still an awesome place. Yeah, yeah.
I'm wishing everyone all the best in this journey, and thank you, doctor, for taking the time and informing us.
Oh, my pleasure.
If follicles are under 10 millimeters on day 6 of Stims, would you start cetrotide?
No. Definitely no.
I love the definitely no.
Yeah, no, you shouldn't be starting it till they're at least 12 or 13, or your estrogen level is higher. So, no, I wouldn't be doing that.
Beta question.
Beta question?
Yeah, exclamation mark, exclamation mark.
Okay.
If first beta was 846,
Okay.
second beta was 8100,
When?
and third beta is 4500, 45,000,
45,000.
45,000. Is that okay? All betas are 1 week apart, but doc is conflicted with how far along my stepdaughter is.
Okay, what? So the first beta was 800.
846. Yeah.
The second one was a week later.
Uh-huh.
Okay, so hang on.
8,100.
Okay, so 2 days later, it should have been 60%. So let's say another 500, so 1,300. And then another 2 days later, it should have been another 60%. So you're looking at about 700 and something. So let's say 2,000. And then another 2 days later, yeah, 8,000. That's super high.
Super high.
And then a week later, 45,000. So 60. Yeah, I mean, that would be totally reasonable.
Totally reasonable. That's what I thought.
Yeah, that would be fine. I wouldn't be worried about that. I mean, it's meeting kind of minimal criteria, but keep in mind that once you're getting into the thousands and thousands, it does start to slow down. You're not going to go 45,000, 90,000, 180,000. It slows down as it approaches the peak of around 100,000.
What are you drinking, says somebody.
Which one was this? The acai
Yeah.
blueberry green tea. I'm drinking acai blueberry green tea. I don't drink. I don't know if any of you know that. How many of you knew that I don't drink? I've never had a drop of alcohol in my life. So I vigorously stay away from that stuff. And I drink a lot of green tea.
Hey, Dr. V.
Fight off the cancer.
There you go. Hey, Dr. V. What is the best way to find out if your progesterone is low?
Blood test on day 23 of your cycle, or if you're doing stimulation, then depending on what kind of stimulation you're doing in the stim process at some point. But if you're just doing it natural, we would check it on day 23. Now, in a natural cycle, there is no real measure of what a low or high progesterone is. No one knows exactly what's necessary because we don't know about every single pregnancy and there's no way to detect that. But in a stimulated cycle, we have a pretty good idea of what you need for progesterone levels to make an embryo transfer work. So US units, you're looking between 10 and 30. Canadian units between 40 and 100. And then if you have endo, you need it much, much higher than that. It's around 45 or 150.
I'm going to do my 4th IUI.
Okay.
Had one successful IUI 3 years ago. I am 38. Doctor will do up to 6. Does progesterone delay my period? And what do you think about the Gonal F injection? And I think she's in Toronto. She put in.
So progesterone can delay your period if you continue it and you're not pregnant. That is possible. It's famous that many fertility centers continue their patients on progesterone and estrogen over the weekend during frozen embryo transfer cycles so that patients don't bleed in case they aren't pregnant, so that they're not calling the center on the weekend. We don't do that, but other places do. So you definitely want to, look at that. And then the second part of the question was the first part. So 6 cycles is not recommended at 38. There is data that shows that after 38, a maximum of 3 cycles is appropriate. And then is Gonal F reasonable? Yeah, sure. I mean, Gonal F is a good potent gonadotropin, and we use that frequently in our stimulation. So yeah, there's nothing wrong with using Gonal F.
Any supplements to increase fertility in men?
Yeah. So we just use the ones that are pre-bundled, and I don't like promoting one product over any other. I mean, we happen to use Fertile Pro or ProFertile. They're both excellent products. You can use either one. There's Fertile Aid. There's all sorts of different things. The main agents you want: coenzyme Q10, zinc, vitamin C, D, E, L-arginine, L-carnitine. There's a bunch of different things in there, but those are some of the big ones. ALA is very helpful for guys as well, alpha lipoic acid. Fish oils can be beneficial. So there are many things that can contribute to improved sperm health and performance, but we don't bother trying to sell you, well, you don't sell anything, but we don't try to convince you to buy individual little vitamins. We try to convince you to just buy the ones that are prepackaged because it's so much easier. But if you go and look at the ingredients on any of those, you can individually buy them. And if for whatever reason you want to do that, that's perfectly fine.
Does endometriosis affect someone's ability to donate?
Definitely. We would never take eggs from a donor with endo because it does directly impact the egg quality. So we can't do that.
What can be done to help with low sperm motility? Smoking has stopped 8 months ago, and taking high quality supplements and started acupuncture. Anything else?
Frequent ejaculation, cold therapy, no drinking, no marijuana use, no vaping, no chewing. Like, stay away from all of it. Make sure there is no nicotine in your system. Exercise. If weight or cholesterol are factors, you should address those as well. All of those things have been shown to improve sperm quality. I love your facial expressions. They're absolutely priceless.
Do you allow partners in the room where the guy provides his sperm sample?
Yeah, all the time. Yeah.
I'm currently 20 weeks pregnant.
Why did that require?
No.
Currently 20 weeks pregnant.
Yeah, currently 20 weeks pregnant. Is it normal to still have a subchronic hemorrhage measuring 5.9 centimeters?
Whoa. Not normal and very concerning at that size. So I would be concerned for sure. I would want you to very much be cautious and follow up with your obstetrician. That needs careful observation. So yeah, make sure you're seeing your OB.
Is it normal to have increased intracranial pressure during pregnancy. I got referred to an ophthalmologist and he said my optic nerve were inflamed and referred me to neuro. Now I'm pending MRI and MRV.
Yeah, it's normal to have some increase. Keep in mind your blood volume is much higher, so your intracranial pressure does increase. Not to the point where you should be getting optic nerve issues, but you will see some increase for sure.
Go back to Facebook, YouTube. Good evening. My FSH result at 11 this month, but in July it was 8. Is it normal for FSH to fluctuate each month?
AMH or FSH?
F.
Oh, yeah, FSH can bounce up and down like a yo-yo.
Is there anything I can take to lower my FSH? Thanks.
No, not really. I mean, no one pays attention to FSH anymore. It's a very insensitive and non-specific marker. So I actually wouldn't pay attention to your FSH. If you're concerned about how strong your ovaries are, you probably want to look at your AMH. And no, within reason, there is nothing that really alters your AMH. There are some things that you can use here and there, but realistically, no, there's nothing that actually helps it. Your facial expressions are priceless. Yeah. Fire away.
You ready?
I'm always a little, afraid.
This is super easy.
I'm always a little afraid, but when I see your eyebrows wiggling over there,
I'm just trying to understand. I'm just trying to understand.
Okay, fire away.
So my wife is 38.
Okay.
And
your wife personally?
No.
This person's wife.
This person's wife.
Oh, okay, all right, yeah.
So this guy,
Yeah.
wife's 38.
Okay.
He's 35.
Okay.
Trying to get pregnant for 6 months.
Okay.
We couldn't make it.
Okay.
Okay. We made out every day except her periods.
Okay.
Does making out so much cause the not getting pregnant? Should we see the doctor?
No. If you're talking about having frequent intercourse, assuming by making out you're referring to intercourse, every day or every 2 days is fine. Should you see a doctor? Yes. 6 months at 38 years of age for a woman is time to see a fertility specialist. At that point, you're running out of time slowly because the ovaries do tend to get weaker. And so we would recommend that you at least be seen. I don't necessarily recommend that you need treatment immediately. I mean, it's so bizarre to me that so many fertility centers just plow people into IVF without even figuring out what's wrong, or if they have a chance of getting pregnant naturally, or if they just need a little bit of assistance. So it's not necessarily that you're going to need some kind of therapy, but you do need investigations to rule out that you need therapy, because if you need therapy, the sooner you do it when your wife is 38, the higher your chances are going to be. So definitely go for investigations. Make sure you're working with a team of people that are committed to your well-being, and then sort it out from there and see what they tell you is going on. But get the testing done for sure. And don't forget that it'll probably take you a little while to get in to see the fertility specialist. And then once you've seen them, it takes a little bit more time to do your test. So that can chew up a chunk of time. And then now she's potentially closer to 39. I obviously don't know exactly when her birthday is, but she'll be that much closer to an older age. So you want to make sure you're being as expeditious about this as possible.
Hey, Dr. V, what is the best way to find out if you're... Oh, sorry, I did that one. Hi, Dr. V and Sidekick T. What's your opinion on getting an endometrial scratch?
Oh, yeah, someone asked me this the
after
other
a failed
day.
FET and before the next one? I hear it's the thing. My clinic didn't offer it, but I hear it's the thing.
So endometrial scratch, I genuinely believe it's probably the most controversial thing in all of fertility. There are so many studies on it showing either no benefit or a benefit, and it's very confusing. Overall, it does not appear to be beneficial. It may be beneficial in people with recurrent pregnancy losses, but the whole thing just doesn't make sense, guys. So I'm not a big fan. I have done it before, and I used to years and years and years and years and years ago, but I don't anymore. And there's another reason to believe it probably doesn't work that well, although it gets confusing. So all the people that did the ERA test are people that ended up with, having endometrial biopsies 1 month before, or at least hopefully 1 month before, and then program their cycle to their ERA. In theory, in the randomized controlled trials of ERA versus no ERA, you should have had more pregnancies in the patients that did the ERA. It's actually the opposite. So I don't believe the endometrial biopsy really does very much. Maybe in specific selected populations, recurrent implantation failure, recurrent miscarriage, I don't know. But it definitely has been pretty much ironclad proven not to be beneficial in patients who are just unselected. Like one previous miscarriage, that's not a reason to pursue doing an endometrial biopsy, at least in my opinion.
I don't know how you stay professional.
Who said that?
Viewer.
I have to stay professional. I don't get a choice.
Yeah, sometimes it's...
Yeah.
I'm lucky I'm off camera sometimes. I think.
You're definitely lucky you're off camera, yeah. I gotta just burst out laughing when it's funny. Like boofing.
Boofing. That was a lesson in life. Let me tell you.
That was a lesson I didn't need.
Yeah. No one needed it.
Yeah.
Yeah. Okay. Question.
Oh, yeah.
In theory.
Okay. All right.
Would taking antioxidants, help a mosaic embryo transfer self-correct?
Oh, what an awesome question. No. Not in the slightest. Not by any biological mechanism I can think of. But I've never read anything about that, and I certainly don't believe there is any info on that. Now, there is an acceptable rate of background mosaicism that can be associated with completely normal babies. So that's number one. Number two, we don't actually know what mosaicism is. It could be contamination. It could be an error in DNA amplification. It may be that those embryos are completely normal or completely abnormal, and we're misreading the testing, or the test itself is being improperly detecting things that either are or are not there. So mosaicism is a big question mark, guys. It doesn't really make sense that a high-level mosaic embryo, which has more than 50% of the cells being genetically abnormal, would result in a normal pregnancy. That just doesn't make sense. But in up to 20 to 30% of cases, it can. So, something's going on there, and it's most likely the testing rather than the actual embryo itself. But it's really hard to figure this stuff out. I did recently meet someone who is working on the ability to actually sequence individual cells from a biopsy for their whole genome. But that's probably a little while off. And once they do that, we'll actually get the answers to the whole mosaicism thing. So it'll be very cool.
Thanks to you and the amazing staff at VRC, I am 6 weeks pregnant.
Yay! Congratulations.
What are the chances of miscarriage at this point? Euploid embryo. It is difficult waiting for my ultrasound. Oh,
I'm sorry. With us, about 5%. So there's still a 5% chance of miscarriage. We don't know why, but there is. It's much lower than what's in the literature. It's usually somewhere between 10 to 15%, but we do still see some. Yeah.
Any success rates with IUI in a woman in their 40s?
In general, with 3 chances of IUI, you're looking at somewhere around a 10% chance of having a live birth.
I don't know what to do with this. I know the microphone's not picking it up, but it's just out of control.
You could probably duck under and pull that chair around, but that's a lot of work.
Yeah, it's a lot of work.
That's a lot of work, yeah.
Stage 4 endo.
Yeah.
And completed 6 Stims cycles, low AMH, age 36.
Sure.
I have 6 blasts yet to PGTA. What is the
6
best?
blasts and 2 are PGTA?
No, and have 6 blasts yet to PGTA.
Oh, yet to
PGTA. They have not been PGTA.
But they're frozen? Okay, don't thaw them and use them for PGTA. But anyways, go ahead.
What is the best transfer protocol? I plan on Lupron down regulation. Is Lupron plus let down regulation better?
Yes. Lupron and letrozole for 3 months, then just letrozole. Minimal or no estrogen for the stim. 5 supplements, NAC, coenzyme Q10, curcumin, ALA, and resveratrol. Double progesterone, so vaginal and injectable. High dose, like around 150 nanomoles per liter, or 40 to 45 nanograms per mil. And then a really good embryo transfer. If your uterus is retroverted, you need a transvaginal guided ultrasound. So make sure they do it the right way.
It's a good show today.
I love your facial expression. If you guys could see what I would see with this show, you would be laughing your asses off. This is quite funny. Yeah, fire away. We do need to get you on camera
This
soon.
is good today. I'm not. This is great.
Yeah, we're going to need to work on your poker face when you come on the...
Some of these... There's just no chance. Is it true?
Okay.
Is it true
Yeah.
that swallowing your partner's sperm can be just as effective as lit therapy?
We don't know, but there is evidence. Okay, don't get mad at me, ladies. Please do not get mad at me. There is evidence in the scientific literature from Scandinavia. Don't ask me how this ever got published. That women that swallow ejaculate have a lower risk of preeclampsia. And the mechanism is thought to be mediated through immunorecognition, where you now recognize your partner's antigens, and so you're less reactive against them, which means less chance of preeclampsia. So by the same token, if it works for preeclampsia, it should be working to sensitize you to your partner's antigens. Do we know definitively that it works? No. But the expectation is that it would. But we certainly don't know that it works. And there are 0 studies on this. 0. It's my conjecture. But we do offer it to people as an option because it's a hell of a lot cheaper than lit, which is expensive. I got to be careful what I mean when I say we offer it to people. I don't personally offer it to anybody. I just advise that they can do it. Yes.
Red flag. That's it. We're done here today. It's just out of control today. It's just out of control.
There's that professional.
There's that professionalism. It was too much.
Yeah.
Hi, Doc.
Hi.
What do you suggest for stubborn lining instead of estrogen for FET prep?
Letrozole, gonadotropin sometimes. PRP is really good. Neupogen can be helpful. Human growth hormone can be helpful. Vitamin C, D, and E can be helpful. Aspirin can be helpful. L-arginine can be helpful. Pentoxifylline can be helpful. Vaginal Viagra can be helpful. So we use any and all of those.
There's some good commentary on the people laughing over here with us. We're joining the laughter here. We're not alone. During a natural non-medicated FET, can I still go on the antihistamine protocol and prednisone?
Yep. I just presented on, not presented, we just posted on that on all the different platforms we're on, I think. The antihistamine protocol has 0 evidence. There is nothing. I've searched for it twice now. There are no studies I could find. So nobody knows if it works or not, but it can certainly be evaluated. We are actually in the process of doing one for the proton pump inhibitor protocol. So we're going to see about that, but it'll probably be a little while before we get to the prep for that. I've got some master's students at the U of W working on it, so that'll be cool when it's up and running.
When do egg donors with fresh transfer, do we have to take birth control pills?
I don't understand that question. I'm sorry. Egg donors don't need to take birth control pills. If you're trying to do a fresh transfer from an egg donor cycle, then yes, you would need to take birth control pill to prep you. And it depends on when your egg donor is going to be ready. But in theory, you got to stop the birth control pill a couple days after they start their period. Again, in theory, but roughly speaking, right around then, or at the same time. Sometimes it depends on how long it's going to take your uterus to get ready, and how long it's going to take their eggs to get ready. It's a lot of guesswork. It doesn't always work out.
Hi, Dr. VNT. Can you do a letrozole FET without the previous day 21 Lupron shot?
Yep.
Or is there too big of a risk of ovulation prior to lining thickening?
No, you can do it, and if the ovulation starts happening, you just give them cetrotide. So you can definitely do that. It's not a problem. We have patients that hate Lupron, so we do that all the time. The Cochrane database, which is a British-based meta-analysis team. So they assign them meta-analyses on different topics, and they spend forever doing them and then publish them. So the Cochrane database showed that Lupron is beneficial in frozen embryo transfer cycles, which is why we use it, but you don't have to use it. You're still laughing at the commentary. Is it funny?
Yeah. Do you lose...
I'm missing out. I don't have we're in a different venue. We're usually in my office today. We're in the, this is called the Pattinson Island where my colleague works. So I don't have a computer screen. So any commentary on TikTok is exclusively being read by Tarek, who is cracking up in the corner here. So anyways.
No comment in respect to the...
swallowing.
Yeah, that's it. So nah, I'll take baby aspirin instead.
Yeah, exactly. Lots of, I get all sorts of responses. I get women that say, I'm already doing it, in which case it's obviously not working if they're still not sensitized. We get women that will say, okay, I'll consider it. And then I've multiple times had women say, I'd rather spend $20,000 than have to do that. So yeah, it's quite interesting, the range of responses that we get.
For the love of medicine. For the passion of medicine.
Yeah. I don't know how they ever got that study passed.
It's a hell of a study. Hell of a study.
How did you get ethics approval for that one? But anyways.
How did you volunteer for that?
It wasn't prospective. It was
I see.
Questionnaires.
Just questionnaire.
Yeah.
Q&A.
Yeah. I don't think you could get permission for a prospective.
I don't think so. I'm wondering. Q. Mm-hmm. With 9 frozen embryos.
Okay.
What would be a reasonable to expect for a normal, abnormal numbers for a 41-year-old? Would you recommend trying IUI at all or go straight to a FET? Thanks.
Normal numbers probably depends on your AMH. I would guess yours is a little bit higher because you got 9 embryos. So I'd probably say about 70 to 80% of them will be genetically not normal. So you're hoping 1 or 2 of them are good and the rest are probably not. Would I go to IUI? Probably not. I mean, if you've got good embryos, that's your best chance. So I'd probably go straight to that. There's no benefit to delaying to try an IUI.
You work with anyone in New York?
No. In fact, I don't. And we have many patients coming to us from New York. However, if you are going to New York, the only doctor I know of that is knowledgeable is Lucky Sekhon, Sekhon. First name is Lucky, like Lucky. She's lovely, and she's now a social media darling. And she works with RMA, which is definitely a good institution. Do I think that they're exactly like us? Probably not. But do I have a lot of respect for her? I do. So she would definitely be one of my go-tos if I was going to New York and had to be in New York. But if I had my choice, I would just come here. Mostly for Tarek. He's just the best.
Okay. Hey, Dr. V. When you do modified natural cycles for your patients, what does it entail and how do you know it's right for that individual patient?
So a letrozole cycle is best. followed by natural, followed by hormone replacement therapy. So we typically will do more letrozole cycles than natural. But some people don't respond to letrozole. Some people are allergic to letrozole. Some people's lining doesn't get thick enough on letrozole. So that's someone where I would consider a natural. And then what was the other part of it? Can you use a trigger?
No. Modified natural sex fertilization, how do you know it entails, and how do you know if it's right for the individual patient?
If you're modifying it by triggering, you can. If you're modifying it by using letrozole, I mean, it's better for everybody. They've shown that. So that's how we choose it. Like, we use it for everyone. So it depends on what you mean by modified natural. And then we always use progesterone. We try aggressively to avoid as much estrogen as possible. It doesn't always work. Many of our patients need a smidgen, but then we're really giving them very low doses of estrogen, which is probably why our success rates are so high.
This is an incredible question.
Okay, I'm ready for incredible because we got 3 minutes left.
I'm almost 44.
And then I got to get home to the kitty.
You absolutely do.
I love our new cat.
Almost 44.
Almost 44.
You ready for the kicker?
I'm ready for the kicker.
We have 14 kids.
Wow.
And I'm hoping for one more.
Okay.
Is my egg reserve greater? I've spent many years pregnant and nursing. My eggs are older, but I haven't ovulated as many eggs as most 44-year-olds.
That's interesting.
Right?
Yeah, because she's had so many kids.
She's had so many kids.
You can find out. You just need your AMH tested. In theory, yes. Although some of your eggs die off even while you're not menstruating because you're pregnant or you are breastfeeding. But in theory, you could have a higher ovarian reserve. However, on the flip side, there would be enormous risks associated with that many pregnancies from the standpoint of hemorrhage of your uterus, some of which are life-threatening. So I would want you to have a very long talk with your obstetrician before engaging in something like that.
I just had, I believe, a successful IVF cycle with my doctor.
Okay.
Implanted 3 of 3 day embryos. Just had ultrasound today at 5 weeks with 2 sacs. One shows baby, and doctor says other one could still be growing in other sac, maybe twins. I'm 43 years old and wondering your opinion, chance could have healthy babies since untested. I have no health issues nor husband, so really praying healthy.
There is no way to answer that question. I'm sorry. I mean, the fact that they saw a sac with a baby is helpful, but until you see a heartbeat, it doesn't mean a whole lot. It's a very good start. I don't want to discourage you. You've got the basics there, but you need a heartbeat. I'm not quite sure why they would have ultrasounded you at 5 weeks. We don't start till 6 or 7. And at that point, you should see a baby with a heartbeat. So I wouldn't make too much out of it if you're just 5 weeks. Wait until you're 6 weeks and get rescanned.
Have you had successful transfers with couples that have a partial DQ alpha match? Which protocol would you use?
Yes, we have. You can use LIT. You can use intralipids. You can use heparin. There's a variety of different approaches.
What is the highest amount of gonotrophins you will use for a 39-year-old woman that is a poor responder to meds? I have a normal AMH, FSH, and AFC count, but respond poorly even at 750 IU per day.
Oh my God. Don't do that. It's terrible for the egg quality. So I would much rather just do a couple of cycles for you or a duostim cycle for you. There are ways to improve your responsiveness. So no birth control for sure. DHEA, testosterone priming, human growth hormone priming. We normally don't go over a total of 375, occasionally 450, but I try and keep my level at max at 375. That's what's going to give you the best results. You don't want high doses of gonadotropins. It's bad for the eggs. And do not take 750. That's maniacal. I don't know who even gave that to you. So yeah, I wouldn't be taking levels that high. That does have damage potential for the eggs.
6 FETs and only 1 pregnancy that ended at 5 weeks.
Oh, I'm so sorry.
High SSD antibodies, no lupus confirmed, male factor. Transfer meds include 100 milligrams aspirin, Lovenox, oral estrus, vaginal progesterone.
So I can only tell you what we do. We don't use estrase if we can avoid it. We use letrozole. You would need to do double progesterone, vaginal and injectable. You need your levels checked. Lovenox and aspirin and steroids and all that are fine, but you would want to know other things about yourself. What's your microbiome like? What's the uterine microbiome, the vaginal microbiome? What's your thyroid like? What are your vitamin levels like? Body mass index? What's his sperm quality like? Does he have high DNA fragmentation? There are many things that would go into it. Do you have endometriosis? Like, don't transfer more embryos. You need answers first. So make sure you get your answers. It makes no sense for people to just keep transferring embryos. One of the biggest pet peeves I have is this idea that people should just keep transferring embryos until they're pregnant. Yeah, great. Like, if you have unlimited resources or you're insured, so it's somebody else's money, and you don't mind having to do all the shots and all the injections and the retrievals and all that stuff and go through the grief of transfer after failed transfer after failed transfer, okay, sure, you can go ahead and do it that way. But like, it seems horribly cruel and very wasteful and potentially hazardous to me. So we want it to work on first try. And if not on first try, then for sure by second try. If it's not working by the second try with us, I'm hitting the brakes and figuring out why. I never tell people just keep doing more cycles of IVF. Sure, at the beginning, I'm going to manage your expectations. And as a general rule, fertility specialists in Canada do not a great job of this. Sometimes even fertility specialists in other places. We need to tell people what to expect better. And so I've really worked hard on doing that, where we tell you now, you're this old, you have this AMH, the sperm quality is this, all the other factors. You're going to need 1 cycle, or you're going to need 2 cycles, or you're going to need 3 cycles, or you might need 6 cycles. I mean, I'm going to tell you in advance what to expect, because if you go into it thinking 1 and done, and you find out at 40, whatever you are, that you need 3 cycles because you didn't even get 1 single normal embryo, it can be devastating. So there's no question you need to know in advance kind of the truth about what to expect, and then based on that, make decisions moving forwards. 9 o'clock? Well, it's past 9 o'clock. Tarek's terminal question. Pick somebody good. Any TikTokers? Or are they still talking about swallowing sperm?
No. I guess we all. Although some people think this is the most hilarious episode they've ever seen.
It was pretty good. Yeah.
We'll take. You have so many unanswered questions.
Oh, really?
You had a massive. A lot of people on today.
Okay. You want to spend 10 more minutes?
Whatever you want. I'm here. I'm right here.
I realize that.
Yeah,
Thank you. Thank you, Captain Obvious. All right, fire away.
What are your thoughts on lit and tacrolimus for RPL?
My thoughts are no one should be getting lit or tacrolimus unless they've proven that they need lit or tacrolimus. So I almost said... The show is off the rails today.
Focus.
I'm sorry. Lit and tacrolimus should not be in the same sentence. So there is testing that can be done to determine if your body merits being the recipient of lit and tacrolimus. And if that is the case, then you need to be evaluated. And I think we're going to need to end the show because I've got a phone call. Have a good night, guys. I got to take this call. I am on call. We will see you next week on Fertility Fact or Fiction. Bye now.